Welcome back to the equine anatomy lectures. We're going to continue today the anatomy of the equine forelimb. But before we do that, we just have to kind of give a summary about the previous lectures. I've talked about the clinical relevance of the forelimb in equine. I also talked about the different articulations, the 6 different articulations of the forelimb. After that, I did talk about the muscles and the innervation of those muscles and injury to those nerves, which basically will lead to atrophy of the muscles and different gait problems. After that, we did talk about the passive stay apparatus of the different joints. We talked about the passive stay apparatus of the shoulder. We talked about the passive stay apparatus of the elbow, of the carpus, of the fetlock, and we gave a summary slide about the different structures that will participate in this passive stay apparatus. After that, we talked about the digits. We started by the fetlock, then the pastern, and then the coffin joints. We all talked about all the clinical conditions that affect the digit, and we reached a clinical case that's we called navicular disease. We reached a point where we talked about the treatment option for navicular disease, and I mentioned last time that one of the treatment options for navicular disease is palmar digital neurectomy. Palmar digital neurectomy. So today we're going to be talking about this and continue to talk about the hoof and the different problems in the hoof. So basically what you do is first you have to diagnose the navicular syndrome, and you do that by physical exam, by placing your hoof testers on both sides of the hoof. And I'll talk about that later when I talk about the hoof regions anatomically. So we'll talk about that later. But for now, we put the hoof testers on both sides of the hoof, and we press so we can get a reaction from the horse, painful reaction. Horse flinges basically, reacts to the pressure. And then after that, we do what we call palmar digital nerve block. PD nerve block, and by that I mean is we put a local anesthetic in the area that has the palmar digital nerves on both sides, medial and lateral. And if the lameness is gone from the horse, if the horse gait is improved significantly, we know, of course, after we take some radiographs and some nuclear scintigraphy sometimes, that there is a navicular disease. And so we reach a point where we need to treat that disease. And by treating the disease, I mean to take the innervation of the area, to take the innervation of the navicular bone. And that's by cutting the palmar digital nerves on both sides. And here it shows in this picture the site of incision, both medial and lateral side on the pastern joint, especially on the second phalanx, just below the ergot. This is the ergot where the surgeon's thumb is. This is the ergot. It's called the ergot. And so just ventral to that on both sides, medial and lateral, we make our incision. After we open the skin, we find a bundle that contains artery, vein, and nerve. And of course, the vein is going to be the blue, the artery is going to be the red, and the nerve is going to be the yellow. And more importantly is the structure on top of the artery, as we can see in this picture, and that structure is called the ligament of the ergot. The ligament of the ergot. We have to be very careful when we cut the nerve not to confuse it with the ligament of the ergot. That is considered illegal, and it's a case for liability against the veterinarian, just like cryptorchid surgery and just like rectal tears. So this is a very important. We have to be very honest about not taking the ligament of the ergot, and instead we have to take the nerves. The treatment is taking out the nerve. It's called neurectomy, palmar digital neurectomy. However, we will look at the area, and we will see the ligament of the ergot. The way we're going to distinguish between the ligament of the ergot and the palmar digital nerve is basically by the color and by the appearance. Usually, the ligament of the ergot is pretty white and pretty glossy, shiny. The ligament. However, the nerve is going to be a little on the beige side, or beige in color, if you will, and also it has to be dull in appearance. It's not going to be as shiny as the ligament. So we have to be pretty specific about that, pretty careful about that, not just to cut the ligament of the ergot. Here's the way we expose the nerve. Take a hemostat basically, and try to separate the nerve from the bundle that contains the nerve, vein, artery, and also the ligament. We separate the nerve, and after we separate the nerve, we take about an inch or so from that nerve, and we cut it, and we cut it on a piece of paper or a board, so we can take it. Sometimes we should, some people will take it to histopathology and to analyze the tissue to be a nervous tissue, to make sure that's, again, I mean, you have to protect yourself just in case, some owner will say, oh, well, you did not take the nerve, you took the ligament of the ergot. This is something to protect you as a veterinarian, as a practitioner, to say, okay, well, no, actually, I took the nerve, and here's the histopathology. It shows that there is nervous tissue here rather than ligament tissue. So basically, that's to protect yourself. And this surgery is done on both sides, as I said, medial and lateral, because there are two nerves, palmar digital nerves, on the medial side and on the lateral side. One nerve on each side, and the procedure is called palmar digital neurectomy. This is another technique for that. It's called the Black's technique. Which is the same thing, but instead of one incision, we make two incisions, both medial and lateral, and we make sure that what we expose on the first incision, we can basically retract on the second incision, just to make sure that yes, this is the nerve that we are talking about, and it's not some other tissue that we need to cut. So this surgery is, again, either technique is a surgeon's preference. This technique has its advantages, and the other has its own advantages as well. But the key point is that you have to cut the nerves rather than the ligaments on both sides, medial and lateral, of the ergot. That's very important. So that's how one of the treatments for the navicular disease, basically. Now we reach the hoof, and this is the hoof here, and this is P3, or the coffin bone. This is the coffin joint. This is the pastern, and this is the fetlock. So this is the part or the structure that we will be talking about right now. The hoof. And the hoof is the keratinized epidermis of, or that covers P3. Just look at your finger and look at your fingernail. This is the hoof, is the fingernail of the horse. So it's a keratinized epidermis. Remember that. Keratinized epidermis. We have a dermis here on top of P3, on top of the coffin bone, the third phalanx. We have dermis, and the hoof is the epidermis. Now, P3 and the joint are all embedded or covered or buried in the hoof. In the hoof. That's why the joint is called coffin joint. Coffin joint, because the joint is buried. The joint is buried inside the hoof wall, inside the epidermis. Inside the epidermis. The hoof consists of three main regions. Three main regions. First one is the wall of the hoof, or the hoof wall. The second one is the sole on the ground, sole. The third one is the frog, which basically covers what the sole left uncovered. So there are three divisions of the hoof: the wall, the sole, and the frog. Now, the wall has also three divisions: a toe, a quarter, and a heel. Toe, quarter, and heel. The sole has angles of the sole, and then the frog consists of an apex and bulbs. Apex and bulbs. So the hoof consists of three parts: wall, sole, and frog. And the wall consists of three parts: toe, quarter, and heel. The sole consists of two parts: angles of the sole. And the frog consists of two parts: apex and bulbs. This is the hoof as we look at it from the ventral aspect. As we look at it from the ventral aspect. Now here, looking at the solar surface of the hoof, we will see that we have the frog, which has the apex and also have the bulbs. And we have the wall, which has the toe, the quarters, and the heels, and we have the sole. So again, the hoof consists of three parts, three main parts. First, the wall, this here, and the sole, which is here, and the frog, which is here. Now, the wall consists of toe, which is the tip of this here, we call it the toe, and the quarter on both sides. and then we have the heels. Now, the frog has the apex and then the bulbs. All of them together make the hoof as we know it. Now, wool consists of toe, quarter, this area right here, and then heel. Sometimes in the wool you see cracks, and we call that seedy toe. Seedy toe, cracks in the hoof wall. Sometimes you will see the wall leaking. The horn that's supposed to make the keratinized tissue. This horn becomes infected, and we call that canker. Canker. Sometimes we see infection of the wall angles. This angle and this angle. This is the infection. This is after it was cleaned. And here they're having to culture it. But you can see the infection here and here. We call that thrush. Thrush. All of this in the wall. Now in the sole you have one of the most common clinical cases in equine practice, and that is sole abscess. Of course, this is the solar surface of the hoof, and of course it's exposed because it's in direct contact with the ground, with dirt, and with sometimes with sharp objects and things like that. And with that, what happens is the sharp objects or things like that, or even stones can puncture the sole, and then bacteria enters, and then the infection starts. Of course, it causes severe lameness, severe pain. We call that non-weight bearing lameness, or touch toe lameness. And the diagnosis of this is pretty easy, because from the case history, from what the owner is telling you, they're going to say, okay, well, this happened all of a sudden. Well, all of a sudden, you don't have too many options. It's either there's a fracture that happened in the bone, and hopefully this is not the case, or in general, this is what it is. It's a sole abscess, some sharp object, a nail or something, or a stone, punctured and went inside and became pretty painful. So the way to do it is basically, the first thing to do is to start cleaning with your hoof knife, and cleaning the whole area, so you can basically expose the abscess, so you can treat it. This is another hoof abscess, or solar abscess. Same name, same case. Open and ready to drain. And of course, when you open it, you have to drain it, and this is the way you treat it, with some Epsom salt several times a day, just to make sure that it's open and it's drained and clean and everything. Now, sometimes you have to go further than that. If the wound was deep, you have to try and cover it, and antibiotics and things like that. Pretty important. And sometimes you even cover it with this nice boot with duct tape and things like that, so you can cover it and make sure that everything is well maintained until healing process takes place. One of the uh, surgical procedures that can be in cases of deeper infections of the hoof. The frog can also be affected, and to eliminate the deeper problems, if you will, to eliminate the deeper infections from attacking the deep digital flexor tendon, the navicular bone and bursa, and also the coffin joint. There is a surgical procedure that's called street nail procedure, which is basically an opening in the hoof in the frog, as you can see here, to make a window, to open a window, to make sure that this window is basically utilized to drain all of the infection. Of course, this surgery should be done or is done under general anesthesia in the surgery room and things like that. So it's major. But the key is that for us to know where is this surgery done, and this is done in the frog, as you can see on the solar surface of the hoof. Again, to treat solar abscesses, but more advanced cases of solar abscesses. The general cases, 95% or 99% of the cases of solar abscesses are not treated this way. They're treated by cleaning with your hoof knife and then Epsom salt and tetanus vaccination and things like that. Pretty basic stuff, but covering and protecting the area is also an important thing. So basically that's with the hoof abscess. Now we're going to move to another topic, and that is laminitis. But before we do that, let's talk about the structures more of the hoof, the structures that are related to that disease in the hoof wall, basically. So let's start with the lamina of the hoof wall. Okay. So this is the hoof. Here is the quarter, and here is the heels, and this is of course the inside of the bulb. And I said that the hoof is the keratinized epidermis. This is a living tissue. When I say hoof, it's not a dead tissue. Keratinized tissue is not a dead tissue. It's a living tissue. Remember that. It's not a dead tissue. You cannot cut it and just leave and go. You have to be pretty careful. This is a living tissue. Okay, so this is the inside of the hoof, and we have here what we call the internal lamina of the epidermis. Internal lamina of the epidermis. Focus on this structure, please. This is the internal lamina of the epidermis. Remember, the hoof is the epidermis of P3. Is your fingernail, epidermis. So this is the inside of your fingernail. The inside of your fingernail. Okay. Now, the P3 is covered with the dermis. So the hoof has the epidermis, and the P3 has the dermis. Okay? Again, living, breathing tissue. This is not a dead tissue. This is, remember, if you take your fingernail, if somebody took off their fingernails by mistake, blood will come all over the place, and I'm sure some of you might have experienced that. If you wanna see what happened, press on your fingernail for a second and let go and see what the blood supply to the fingernail is. So just press on your fingernail and take it out. Press and take it out for a second, and then see how when you press it becomes pretty white, pretty pale, and then when you take your finger out it becomes pretty red. So that tells you this area is highly vascularized. Highly vascularized. Now why am I saying this? I'm saying this because this part, which is P3 and its sensitive dermal lamina, the external lamina of the dermis, the external lamina of the dermis interdigitates with the internal lamina of the epidermis. They interdigitate. They become one part when P3 goes inside the hoof wall. P3 gets inside the hoof wall. This lamina basically becomes interdigitating with this lamina. Now, this is how they look. So if we look at a piece of that interdigitation, this is, for example, the dermis, the external dermis, external lamina of the dermis, and this is the internal lamina of the epidermis. This is the hoof wall, and this is P3. Look at the interdigitation here. This is where the interdigitation comes, and they become unseparable. Unseparable. Now, remember what I told you about that blood supply to this area between them? Look. This is to show you the intensity of the blood supply to both P3 and the hoof wall. It's all full of blood, just like when you take by accident your fingernail. When you're cutting your fingers and you took more of your fingernail, look at the blood that's coming out. This is how intense this blood supply to the hoof wall is. Now, and this is another picture showing you where these arteries and veins go in between these interdigitations. Let's take a look at a cartoon to see how this relation is established. This is the normal situation, and in the normal situation, we have the hoof wall here, the internal lamina of the epidermis, the external lamina of the dermis, and the surface of P3. I will repeat. So in the normal situation, you have the hoof wall. The inside of the hoof wall, you have the internal lamina of the epidermis. Remember, the hoof wall is the epidermis. So this layer here is the internal lamina of the epidermis. After that, interdigitates with the external lamina of the dermis. And after that, there is the surface of P3. Sometimes, in certain diseases, systemic or local, what happens is this lamina starts to die, and this interdigitation with between the internal lamina of the epidermis and the external lamina of the dermis starts to be lost. You start to lose this interdigitation. So the blood that I told you about, heavy blood supply into this area, starts to lose or to go in between these tiny spaces, microscopic spaces, because the interdigitation is gone, or started to at least. So blood started to ooze into the spaces here. This is the beginning of a case that we call laminitis. Laminitis or foundering. Laminitis or foundering is a very painful clinical case that is characterized by the loss of the interdigitation between the internal lamina of the epidermis and the external lamina of the dermis, which leads to oozing of blood into the area of this interdigitation. Now, if the case continues, this is very painful, by the way, to the horse. If the Case continues. Remember that this is the surface of P3. The surface of P3 is attached from the palmar aspect to what? It's attached to the tendon of the deep digital flexor muscle. Deep digital flexor muscle. The only tendon that reaches P3. This is P3, right here. So the tendon is the only structure that reaches the P3 from the palmar aspect. We know from the dorsal aspect there is what? There is the common digital extensor. But from the palmar aspect, we have the tendon of the deep digital flexor. Continuous pull by that tendon, along with the loss of the interdigitation, leads to separation between P3 and the hoof wall. This interdigitation is lost and P3 is separated. When you separate P3 from the hoof wall, we call that rotation of P3. Rotation of P3. That is the most advanced case of laminitis. And at that point, the horse is in severe pain. And there's very little to salvage the life of the horse. Okay, so I'll stop right here. So we talked about laminitis. And next time, we'll continue on laminitis also. And after that, we'll talk about how we will perform a lameness exam in the horse. So next time, I will continue talking about laminitis, maybe explain it a little more and show more radiographs and things like that. And then I will talk about complete lameness exam and nerve blocks and things like that.